very soon you're not gonna see her, you're gonna see her screen, right?
Yeah.
So there we go, I'm gonna put it to Miss Marietta.
Okay, great. Hi to everybody who's joining us online today. And thank you to everybody who's here in person. I'm excited to have so many people interested. I'm excited to have so many people interested in learning how to use NARCAN and how to save a life. So I'm gonna go ahead and share this screen. And once I get it shared, if somebody could just unmute and say, yes, we can see it, then that will get us started. Share. All right, are you seeing that all right?
Yes.
Okay, thank you. So, once again, my name is Marietta Hagan. I work for Cox Health, and my role is really a community liaison in the community, working with anyone and everyone about substance use. I get to work with law enforcement, with treatment and recovery support organizations, with schools, and my favorite part of my job is really doing this training. So I get to go out into the community and teach a lot of people what you're about to learn. So the point of this training, let me advance my slide here. There we go. This training was created by the organizations that are listed here on the right-hand side of the screen. And the reason they came together is because there's a lot of people dying of opioid overdoses in our area. We're going to cover several topics today. As Rosie mentioned, it's about an hour-and-a-half long class. Hopefully we will answer all of your questions by the time we get to the end, but if we don't, there's going to be time for questions at the end. So the goal, there's a lot written here, right? But the main goal, let's stop people from dying. Let's learn how to save people's lives. That's what you're going to walk out of here with, is some concrete skills that you can use to identify somebody who is experiencing an opioid overdose and then to save their life. So we are going to start it out by talking a little bit about some data, which just kind of helps us to understand how serious the situation is here in our regional area. So first basic knowledge is what causes an opioid overdose, right? Taking an opioid. What is an opioid? An opioid can be a legal substance, or it can also be an illicit substance. These are some of the common names of opioids, both the pharmaceutical name and the street name. There is a difference between opioids and opiates. Opiates refer to those natural compounds that are present. So a lot of people interchange these words, and that's okay. I think we all know kind of what it means, but it's important to know there's a difference between semi-synthetic and synthetic opioids, because synthetic opioids are really what are driving those overdose deaths right now. So heroin comes from the poppy plant. It's that plant that's pictured there. You have to grow it, you have to cultivate it, you have to transform it into heroin. Where fentanyl is a synthetic opioid, that is something that can be created in a lab. And so it's much easier to make large amounts of it, and it's also much easier to make it very strong, very potent. And that's why many of the deaths that are happening right now are being driven by the introduction of fentanyl and other synthetic opioids into the supply. And that's been happening for the last couple of years. So this is just an example of a couple different types of opioids. The first one on the far left is heroin. That dose right there is considered a fatal dose for anyone that is opioid naive, which means that they don't typically use opioids, don't have opioids in their system. If you can see, there's just a few grains here in the fentanyl vial, so that shows that it takes a lot less of fentanyl to kill someone other than it does heroin. And over here in the third vial, there's one little tiny speck of carfentanil in that vial. And that's because carfentanil was originally designed as a large animal tranquilizer. So it was designed to sedate things like elephants and rhinoceros. So it makes sense that even just a very little bit of carfentanil could kill a human. We haven't seen a lot of that here in the Midwest, but there have been reports of that being involved in opioid overdose deaths in other parts of the country, but our coroners are not seeing that showing up in our system supply right now. Mostly it is the fentanyl. Okay, so our really the problem, again, we're seeing more people who are experiencing overdoses, both fatal and non-fatal, it's driving up the ER visits that we're seeing and the hospitalizations. And so basically across the country, people are coming together to educate and to distribute NARCAN to help address this. This is just a snapshot of kind of what I was talking about that introduction of synthetic opioids kind of driving that. So as you can see in like the 2013, 2014 area, the synthetic opioids shot up, and that was when fentanyl was really starting to become a large part of the market. And I'm a really visual person, so I want you to take a good look at this map. This map represents the drug overdose deaths in the US in 2005. And included in those deaths are prescription opioid analgesics, heroin, and illicit synthetic opioids. Now I want you to see how the change over the next, from 1999 to 2016, what that change was. Significant, right? Over a 500% increase. So in that time period, we had more than 630,000 people die from a drug overdose, and more than 350,000 of those were an overdose involving a prescription or an illicit opioid. So you can definitely see it was a dramatic increase in deaths, and it's really caught the attention of media, of political leaders, of everyone in the community, because it is impacting so many people. I'm gonna check the chat really quickly because I see that we have a couple things. Okay, just making sure. All right, next screen. So just talking about state impact, in 2018, and I apologize that it is older data, that is one of the challenges with drug overdoses, is data is lagging because sometimes it takes a long time for toxicology reports to get back to coroners, for that information to then make it to the state. So some of these numbers are going to be a little bit dated, but just in 2018, there were over 1,100 in the state of Missouri. I know that number has gone up, but I can't tell you what that exact number is yet. This graph just kind of shows you the difference where the opioid overdose deaths were related to heroin versus the non-heroin. And so you can see that light purple continuing to increase as we move on. All right, so this slide relates to prescription rates. And in the past, there have been studies done by the Substance Use and Mental Health Services Administration that showed that 75 to 80% of new heroin users, I believe the first study was in 2013, the other one was in 2017, 75 to 80% of new heroin users reported their use starting by misusing prescription medications. And so this slide really speaks to that availability. So in the past, providers were much more likely to give larger amounts of prescription opioids, and that led to a saturation in some areas. So you can see that there was a high amount of opioids available in our two counties. So the one here on the right is that's circled is Taney County, and the long one on the left is Stone County. So when you have a lot of available supply, it can also drive up that overdose occurrence. And then this slide relates to babies that are born with neonatal abstinence syndrome. Again, this is very old data. If we had the numbers that are currently based on anecdotal reports from our delivery units at the hospitals, we know these numbers are probably doubled by now. We see a lot of women who are using during pregnancy, and what happens is then the baby is born with their body being physically dependent on the substance. It can be meth, it can be alcohol, but it can also be opioids. And so what happens is that baby, once they're born, they're no longer getting that substance through their mother's body, and they experience withdrawals. So the baby's not addicted in the sense that it's not having all of these negative consequences like legal issues and marital issues that often come with addiction in adulthood, but the baby is dependent and their body goes through withdrawals. And these withdrawals are horrible, horrible experiences. I've talked to nurses in the Women's Delivery Center who talk about babies that are sensitive to light and touch and sound, who can't feed, who are sometimes their muscles are spasming so hard that you can like hold them in their hand and they're stiff as a board. They're vomiting, they can't keep down food, they don't gain weight. And that's just the immediate effects. There haven't been enough studies done to know what kind of long-term effects some of these children may have from that. So it's a definite thing to be aware of, and one of the reasons why a lot of OBGYN offices are really trying to engage with mothers in their early trimesters, trying to transition them to medications that would be better for the baby. I'm sorry?
I'm saying he's got questions and send it to me.
Okay, sorry. Okay, so this slide talks about past 30-day prescription drug misuse, which I mentioned earlier, but this one is specific to a survey that is done for youth in the state of Missouri. Every 2 years, the youth 6th grade to 12th grade do a survey at school that's related to questions asking them about their behaviors, their mental health, their risky behaviors, things like that. One question that we focus on is how many students have misused a prescription drug in the past 30 days. And then you can see that our numbers have kind of stabled off a little bit. I'm not sure what the 2022 numbers were, they just came out recently. But why we look at this is because youth that misuse prescription drugs are 14 times more likely in the future to use heroin. So this is a good indicator to us of how many at-risk youth are in our community and how much effort we should be putting towards prevention. So thankfully, 10% is kind of the guideline where if your community is at 10% on one of these questions, you need to seriously be doing something. I'm pretty sure our 2022 numbers were down in like the 3 and 4 percentages because we've actively been addressing it in our community the last couple of years. So it is something that we don't have as much of an impact on in our community as maybe other communities do. This also talks a little bit about our local area. So pictured here is Taney County. Our sheriff's department and our local Branson police officers use a system called OD Map to track the overdoses that they respond to. These could be a combination of overdoses from many different substances, not specifically opioids. So this was in 2019 between the ER and Taney County law enforcement. There were probably over 988 suspected overdoses, because we know not every overdose gets reported, right? There's lots of overdoses that are reversed by family members and friends that don't even call EMS. And we also know from the coroner's department that there were 12 of those that were fatal. So one thing we try to do by tracking this data is try to see, are our numbers going up, are our numbers going down? But we also use this data to help agencies like the Brook Wellness Center get access to funding to bring to our community, because there's a lot of money out there right now for drug overdoses and opioid overdoses specifically, but you can't get access to those funds if you don't have good data to show that we actually have the problem in our community. So if you have the opportunity to be a part of a program where you're reporting some of that data, take it very seriously, because it is something that can bring a lot of resources to our area. This is the local impact by Taney County Ambulance Department. They are one good agency that collects a lot of great data. And so you can see by the numbers here that they are going out and administering more NARCAN typically over the years. So you can see a big jump here to the number of administrations that they had from 2019 to 2020. One kind of interesting part of this is there are actually more administrations than the number of people that received Narcan. And the discrepancy is because sometimes people have to have multiple doses of NARCAN given. So if one person receives 3 doses, that's reflected in the difference between the number in the black column and the number in the orange column. So that also speaks to the potency of the opioids that are in our area, because if it's a more potent or a stronger opioid, they're going to need more doses to reverse it. All right, so I want to talk a little bit about Al Vineyard. So in our media, we often hear a little bit or a lot about the negative impacts of overdoses and substance use and everything. And it's created a stigma in our country that keeps people from seeking help. So what I try to do in my job is to really focus on the positive as much as possible. And Al is a positive example of what recovery can do. So Al was from this community. She grew up here, typical A student, went on to serve 2 years in the Air Force, got married, had kids. She was a manager at a local restaurant, and one day she got injured. And like any of us would do, she went to the emergency room and she was put on some pain relievers because she was in pain. Within a week, she went back to her primary care physician for a follow-up, and her pain hadn't subsided, and so her primary care physician put her on a stronger pain reliever. And soon, her body became dependent on the medication that she was on, and within 6 months, she was fully in the throes of addiction. And over a couple of years, she had a lot of engagement with law enforcement. She ended up, I'm actually going to read something to you that she wrote because her words are just way more powerful than mine. So this was a post that she put a couple years ago on Facebook. Let's see, so she's getting ready to celebrate 10 years in recovery. So these photos would have been taken 10 years ago. 5 days before my entire world would fall apart. I was standing on the brink of disaster, and I was too high to realize it. I was sitting in my car, which would be stolen in 2 short days, in some parking lot with my dealer, getting high. My family was in our home with no electricity, and I didn't care. I'm covered in glitter and fresh needle marks. I was so lost, and I didn't care. 5 days later, my kids would be removed from my custody by the Taney County Sheriff's Department. My husband got a restraining order against me, and my house was robbed and ripped apart. 3 felony arrest warrants showed up the next day, and I had a revoked bond, no home, no car, no family, and I thought no hope. Al tried to take her life within 1 week of those photos, and she actually attempted twice. And thankfully, she was not successful and was able to connect to some local pastors that got her into a 12-step program. And I am so excited to report that this is Al more recently. She said, like I said, she's almost 10 years in recovery, and she recently graduated with her bachelor's from Missouri State University. She is halfway through her master's program. She is reunited with her husband and has her 3 children back, and she was recently promoted to assistant general manager of a large entertainment complex here in Branson. And so she, to me, is a celebration of recovery, right? She is surpassing everyone's expectation, and she has become an advocate for recovery. She goes and helps people on their journey. She speaks out about recovery. She's kind of the face of everything that we do because she's not afraid to address the stigma and the shame that she felt whenever she was in recovery. And so she's one of many stories that we have in our community of people who are thriving in recovery. But I do share her story just to kind of focus on the positive and attempt to get rid of a little bit of that stigma that we often see. All right, so there's a lot being done in our communities towards prevention, towards treatment, and harm reduction. We talk a lot about and we hear a lot about those symptoms that are happening, the thefts, the overdoses, things like that. But what doesn't get a lot of attention is some of those underlying causes that brought us to this point. So 15, 20 years ago, overprescription was driving this. Providers didn't know how dangerous this medication was, and they were handing it out like candy, really, because they thought it was not addictive, they thought it was safe, and they thought they were helping their patients. We also had challenges with limited insurance coverage for non-opioid treatment alternatives. So basically what that meant is it was easier for a provider to write a $4 prescription for hydrocodone than to spend an hour and a half on the phone with an insurance provider trying to talk them into letting them cover massage therapy or chiropractor or other non-opioid medications that were too expensive. So there was a lot of barriers put up by the insurance companies that drove physicians just to say, heck with it, I'm just gonna write a prescription and be done with it, right? I will share an exciting news. In the omnibus package that just passed at the end of December, there was included in that a bill called the No Pain Act. And what that act does is it allows for Medicare to reimburse hospitals for non-opioid treatment during surgeries. So previously, what would happen is, for example, my husband went for a shoulder surgery. He had to pay out of pocket for a nerve block that would help with his after pain so that he wouldn't have to take opioids because his insurance would not allow it. We paid the out of pocket because we knew it would reduce the amount of opioids that he would have to take afterwards, and it would be significantly better for him to not have that pain. Well, now Congress has said that insurances have to cover, and Medicare needs to cover those non-opioid choices so that people don't have to rely on as many opioid pills after a surgery. So we also had deceptive marketing by big pharmaceutical companies, typical to what we saw in the 50s with the tobacco scandal. There were representatives out there selling their product to providers saying, oh no, this isn't addictive, there's no problem, go ahead and give your patients stronger and stronger doses. We had a lack of access to evidence-based treatment options and medications for opioid use disorder and other substances. We had a lot of stigma, which we still do. A lack of data was one of those underlying causes. The introduction and importation of fentanyl and other synthetic opioids, and then the cheaper and purer heroin that started to flood in. So all of those things brewing below the surface kind of drove us to where we are now in this endemic of overdoses. All right, so we're going to switch gears just a little bit and talk about the changing legal landscape. There are a couple of laws you guys need to be aware of if you're going to carry and administer naloxone. So the first one was actually specifically for emergency responders, so that wouldn't have applied to you. But in 2016, they enacted the bill that covers the general public. And this bill allows anyone to go into a pharmacy and to request and purchase NARCAN or naloxone over the counter without a prescription. Not over the counter, excuse me, without a prescription. It is a statewide standing order. So before that, what you would have to do is you'd have to go to your primary care physician and tell them you wanted a prescription, you know, take that prescription to the pharmacy and get it covered. Now, this standing order allows anybody to go into the pharmacy and request it, whether it's for them, for a family member, you don't have to have a diagnosis, nothing. It also said that as long as you are carrying and administering NARCAN in good faith and with reasonable care. And what does that mean? That means that you've been trained to identify an opioid overdose, that you're administering it to try and save someone's life, then you do not have civic or criminal liability for trying to save someone's life as a result of that. So that just gives us protection to know that it's legal to carry. A lot of law enforcement officers might pull somebody over. They pulled me over, I've got NARCAN in my bag. And I'm allowed to have it, and I'm allowed to administer it. And that's because of this law. The other law that I'll tell you about is the Missouri 911 Good Samaritan Law. This one's really important for people who are in active drug use. So if you work with people who are actively using, please make sure that they are aware of this law. What it does is it covers them in the event of trying to seek care for someone else that is experiencing a medical emergency. So here's the specifics on it. This, let me just say first, straight out, this law does not cover someone who is manufacturing and distributing and has large quantities of substances on their location when the emergency happens, right? It's not gonna work for them. What it is gonna cover is someone who is maybe in a party situation or using with someone that they know, and one person overdoses or falls and breaks a leg. It doesn't matter what the medical emergency is. It is covering them from having an arrest, charged, prosecuted, convicted, or losing their property as a result of them trying to get help for the other person. So It does not cover more than one person. More than those two people, excuse me. So if you're in a group situation, only the person that's experiencing the emergency and the person who's trying to seek help for them are covered under this. So if it is like a party situation, I'm just saying that disclaimer. The other thing it does not cover are these things. It does not cover it covers this. These are the things it does cover. It does cover possession of paraphernalia. It covers being a public nuisance, alcohol sale to minor. It's very specific in what it covers. What is not covered is anything else, and outstanding warrants. So unfortunately, if one of the two people have outstanding warrants, they can be arrested in that situation. But the law is designed to encourage people to call for help instead of leaving someone to die, which has happened many times where people will just leave and they'll find someone dead later. It also is trying to discourage people from just driving somewhere in a public place or in front of an emergency room and just dumping people out on the sidewalk, because that's happened as well. So it's really important that people in active use really know that those two people are protected and to call for help for someone. If we have any police officers on the Zoom tonight, this does cover, so the responsibilities on scene are related to you having to provide appropriate information and resources. If you are a law enforcement officer and you are not aware of what those appropriate resources are, feel free to drop that in the chat and I'll connect with you afterwards and provide you with some information that you are able to hand out in regards to that. Okay, so we're gonna quickly go over opioid use in the brain, just so that people who are not familiar with opioids have an understanding of maybe why opioids can be so addictive. So we have substance use disorders, right? Those are preventable, they are treatable, and recovery is possible. Recovery can sometimes be very difficult, but it is possible, and we have lots of examples in our community of people who have found recovery and are sustaining it. Substance use disorder is a brain disease. It is classified as a brain disease by the National Institute on Drug Abuse. I want to read the definition for this one word for word because I think it has some very important words in it that we need to be aware of. So addiction is a chronic, relapsing brain disease, right? It means it's forever and it happens over and over. That's why people have return to use. It's characterized by compulsive drug seeking and use, and compulsive means they're not able to control the drive to use drugs, despite harmful consequences. So those consequences could be negative legal issues, it could be money issues, it could be familial issues, relational issues. If someone continues to use, even though they're having problems that are caused by the use and they can't stop, that is part of addiction. It's considered a brain disease because drugs change the brain. They change the way the brain works and its structure. And so I think a lot of times people see it as a moral failing where it's a bad person instead of the drug. And so what I like to focus on is that it is a medical condition, just like my aunt has diabetes that she treats and sometimes relapses because she has a big fat donut and sends her insulin or her sugars way up. It is very similar to maintaining any chronic disease. You're going to have ups and downs, you're going to have to work at it the rest of your life, but again, recovery is possible. I do want to make a distinction between addiction and opioid tolerance and physical dependence. So you may be tolerant, which means that you have to take more of a substance to get the same effects. And you may be dependent on that medication because of the way it works in your body. But that does not mean necessarily that you are addicted in that definition. Because if you are tolerant and dependent, but you are not having those negative consequences, if you're living a successful life, you have a job, you have a family, you're not having those negative consequences, that is not addiction. There are a lot of people who are suffering right now because they are tolerant on a medication. They do have a dependence on a medication, but because of the stigma now that goes along with using opioids, physicians are now afraid to provide that medication to them, and they are either tapering them off or cutting them off right away. And that is unfair because a lot of people are following their prescription, they're doing what they're supposed to be, they're not having negative consequences, but they're being penalized just because of what's happening in society. So to have a substance use disorder, two of your identifiers cannot be these two. Now you could have this and other things and that be considered addiction, but to have a substance use disorder, it cannot be just because you're tolerant and you're dependent. Okay, this is kind of a basic slide, but for me, so I didn't mention this at the beginning, but I am not in recovery myself. I'm a recovery advocate and a recovery ally because my family has been strongly impacted by substance use across the board. And so for me, this was a whole learning process, and this slide spoke to me. My father struggled with opioid use disorder, and helping me understand why he did some of the things he did when I was a teenager, this slide just really spoke to me about that. Also with Al, I used to think, wow, you're a mom. How could you have left your kids in your house for 30 days with no electricity and not give them a thought? This slide really kind of helped me more understand that. So this slide, let's talk a little bit about what dopamine is. Dopamine is a natural chemical that is released in your brain. It's a feel-good chemical. It makes you feel good. And it's part of the way we're designed to survive. So if we do something that promotes our survival, like breathing, like eating, like procreating, our brain says, hey, you need to do that again. And it releases dopamine, which makes us feel good and makes us want to do it again. Unfortunately, substances also release dopamine and sometimes release them in much higher amounts. So when you have food, and I'm a huge foodie, so I'm pretty sure my numbers are way higher than this, but whatever. Food is about 150 units of dopamine. When you have sex, why is that clicker on? Okay, when you have sex, the orgasm is about 200 units of dopamine. When you smoke a cigarette, there's about 215 units of dopamine that is released, and it's released quickly because it crosses the blood-brain barrier. Cocaine is a little higher. We've got cocaine at 300 units. Heroin and methamphetamine, by the way, but because this is an opioid-focused talk, we're going to say heroin, but it's also methamphetamine, is about 1,500 units. So the first time that I saw this slide, my jaw dropped. I was like, what? That seems insane to me. Your brain is not designed to handle this much dopamine release, right? It's used to these amounts of dopamine release. And then all of a sudden, this huge amount of dopamine is dumped into your brain, and your brain goes into shock. So think about your brain as an electrical outlet, right? So if we plug a regular plug into the electrical outlet, it functions correctly. But the reason that they make dryer and washer plugs different is because those have a different power. And if we were to plug a dryer or a washer plug into a regular plug, that amount would blow it, right? Well, electricity is easy. You call an electrician, they rewire it, it's all good. Our brains aren't that easy. They don't come back from an explosion like that as easily. So that's one of the reasons that people are driven to seek substances, even though they're experiencing some of the worst negative consequences they could be. And again, that really kind of helped me to understand in those two situations why someone might do something that normally they would probably never do, but they're doing it because their brain is pushing them to find that release of heroin again, or release of dopamine again. Okay, I just want to check this. Okay. There we go. So there's several risk factors for substance use disorder, and a risk factor, it doesn't necessarily guarantee that someone's going to get a substance use disorder, but it kind of makes it more likely. So somebody could have all of these risk factors and never have a substance use disorder. Maybe they have a great social support system. Maybe they have lots of resources. Someone could have none of these and they can have a substance use disorder. It's really dependent on the individual and the environment. But research has shown that there's one specific risk factor that's listed up there that has more power of telling, I guess, that makes you more likely to have a substance use disorder in the future. Are there any guesses to which one of those is the one that really can impact someone's future? Feel free to unmute. Or
Victims of abuse.
Victims of abuse, that's a good one. You would think that a lot of people would be driven by that, right?
Genetics.
Genetics, it does play a part. Definitely, for sure. It is not the number one.
Or
Early experimentation.
I heard it. Who said early experimentation?
I did.
All right, Randy, you got it. So early experimentation is the number one risk factor, and it's for a couple of reasons. So early experimentation refers to youth using at a young age, right? Part of the reason that it's so dangerous for youth to use is because their brains are still developing. Their brains don't fully develop until they're 24 to 27 years old, and so whatever use they're experiencing, their brain is taking on at a much higher level. Another example of that is that youth who use for a significant amount of time can become dependent and addicted much faster than an adult. So if a 21-year-old is drinking heavily for 6 months to 2 years, they could have a substance use disorder where if a person waited until maybe they were 45 to start really drinking heavily, they may not develop a substance use disorder for 10 or 15 years. And that's because the youth in that 21-year-old age, their brains are still so malleable that it's more impactful at that young age. So yeah, Brandy, good job. Early experimentation is definitely our number one risk factor, and that's why we point a lot of efforts towards prevention in our communities. If we can keep youth from using or even delay their use further years, they have a less risk for developing a substance use disorder. Now in our area, as Rosie can tell you, we have a lot of problem with that because we have generational substance use, familial substance use, where they're introduced to it very early, where youth are saying, my parents are the ones giving it to me at 11 years old. So it does make it challenging. All right, we're gonna pop through a couple of these things. Okay, so I wanna talk a little bit about withdrawals. Like I said, I've never experienced withdrawals from opioids myself. I experience withdrawals from caffeine almost daily. If I don't have my caffeine about 2 o'clock, I start getting my caffeine headache, and I know many of you can relate. So I know that is nowhere in comparison to what someone on opioid withdrawals experiences, but it helps me to understand what they might be experiencing. I've also experienced watching my father go through all of these severe ones listed right here every month for probably 2 years at the end of every month, because he would misuse his prescription opioids and take them too quickly, and that last week of the month he'd run out, and sure enough, he would go into withdrawals. And for the last week of the month, he was vomiting, he had diarrhea, he was muscle spasming, he was in bed, sick as could be. We were taking him to the doctor, emergency room, trying to get him his medication. I, at 17 years old, was on the phone with the doctor's office, begging and calling and asking them to give them the prescription early, because I didn't know. I didn't know that that was the problem. I didn't know he was addicted. So, like I said, I've never experienced these, but I can understand why someone who is experiencing them would do anything they could to avoid this, because I would not wish that on anyone. What I watched my father go through, I would not wish that on anyone. And I can understand how he may have done some things that he probably shouldn't have in order to make that stop. So be aware that it can range, it does get worse the longer they are in withdrawal, and there are some medications that have a long half-life and can cause the withdrawal to last up to sometimes 14 days. So someone who is in recovery, Dave Stoker, he always says that it's like the flu times 100, and it can last 10 to 14 days. All right, so I did not know this, but what I've learned over talking to people who have been in use for many, many years is that eventually the euphoria wears off, and it has to do with that tolerance and dependence. So in the beginning, they were using opioids and they were getting the high, they were getting the good feeling, the euphoria. And then I remember Al telling me about this specifically, that as she got to the end, she wasn't even experiencing the high anymore. It was simply to avoid withdrawals. She would get up and start her day figuring out what she had to do to get her next hit so that she wouldn't go into withdrawals. And I can understand that. I mean, thinking about my dad and seeing the things, I would be pretty forthright on my mind to make sure that that didn't happen to me. So there are some medications that are available to help people deal with the withdrawals and to help them get into recovery. We're not going to go really deep into these because we do have treatment providers that are available to talk about these, but just know that there are some really good opportunities, especially now, because 5 days ago, Congress again passed a bill that gets rid of the barrier that we had before. So previously, doctors had to have a special waiver from the DEA to prescribe this medication in the center here, buprenorphine. And it was a huge barrier because doctors didn't want to go through the extra training and they thought it was a liability on their license and they didn't want to get the license. And they were also limited in the number of patients they could treat. So even though we have this great, amazing medication that can help someone not have to go through those withdrawal symptoms, it wasn't accessible. Now, because the X waiver has been terminated, that is no longer the case. All we have to do now is educate our providers that they are allowed to do this and educate them on how to use it, and we can save a lot more people's lives. And what those medications do is allow someone to get back into that normal range where, yes, it is an opioid-based product. The buprenorphine is an opioid, but it doesn't typically cause that euphoria, and it keeps people out of withdrawals, which is what you want to avoid. All right, so now we're going to get into talking about naloxone. So you'll hear me interchange the words naloxone and NARCAN often. A lot of people do that. Let me tell you the difference. So you know how we call Q-tips? Well, that's a brand name, right? They're actually cotton swabs. They're not Q-tips. Q-tips is the company that makes them. It's what they're called in that company. Same thing with Kleenex. Kleenexes are tissues. That's their generic name. Tissue or Kleenex is the brand name. So think about that when you think about naloxone and NARCAN. Naloxone is the pharmaceutical company generic name. NARCAN is a type or a brand of naloxone. So the medication that's in NARCAN is naloxone, it's just administered in a different way. But most people are so familiar with the word NARCAN that if you say that, they're gonna know what you mean. If you say naloxone, they may not know what you mean, so I typically just say NARCAN. So, naloxone works. I'm sorry.
I have a question for you. So people that don't use any kind of medications or anything that are not prone to this stuff, I mean, is it worse or better? How's that?
I'm not sure I understand your question. I'm sorry. Can you?
So basically, I don't take any medications because I'm against all that kind of stuff. So I don't know if I would be wanting to do something like this for my addiction problem.
So are you asking about buprenorphine or NARCAN and naloxone?
I'm talking about the stuff before this.
Oh, okay. Buprenorphine, yes. You know, that's a personal choice. There are some people who do not want to continue on buprenorphine because technically, like I said, it is an opioid, and there are people who don't want to be dependent on any kind of opioid, even though they're not an addiction. They're using it to maintain. There are some people that choose that, and that's totally a personal choice and a choice with your provider. But I will let you know that there are many people out there that live the rest of their lives on buprenorphine successfully. They have successful lives, they are in recovery, but they do take buprenorphine every day, just like my aunt takes her insulin every day, and my grandma takes her blood pressure medication every day. So that is a total personal choice, Anthony. I totally understand that. There are several people out there that share those views. Did that answer your question? Was I understanding that right?
Yeah, pretty much. I mean, my mom's told me about methadone and stuff, and I'm just an anti, pill taker or whatever.
Yeah.
I don't like stuff like that. I feel like it affects your brain and your chemistry a little bit differently.
I get that.
So I think that he wants to know if you don't take any medications at all to get off of it, is there anything else that will help? Am I right?
Yeah, pretty much. That's close to what it is.
Okay.
We don't want to do that, I mean, the only other way to get over this is how. I mean, this
So
is
there's a withdrawal.
Yeah, I see what you're saying. Yes, so you're right. You would have to physically go through the withdrawals. You could work with a provider to treat the symptoms of the withdrawal, so they wouldn't be able to stop the withdrawal, but they could maybe treat the diarrhea with Imodium and the vomiting with Zofran, and they could treat the symptoms and get you through that horrible withdrawal process. And then, yes, there are other ways to find recovery from opioid use disorder without the use of buprenorphine. Some people use 12-step programs, some people use CBT, there's lots of evidence-based treatments out there that are not dependent on you taking pills. So that is definitely an option, Anthony. And one that I would invite you to, whichever provider you work with, to explore those, because it should be your choice. If you don't want to take buprenorphine, then we need to find something that works for you. Okay.
Appreciate it. Thanks so much.
Sure, my pleasure. All right. So the naloxone works in 3 minutes, and how it works is, think of opioids floating through your body, right? We've got opioids all over our body. They are out there, opioid receptors. We have opioid receptors all through our body. And when you introduce opioids into your system, no matter how it's introduced, they attach to those receptors and they activate those receptors. And that's what blocks the pain, that's what gives you the feeling of euphoria, is the opioid attaching to those receptors. The cool thing about the receptors is they really love opioids, like they'll keep hanging on to them. But if you introduce naloxone into your body, it likes naloxone so much more that it will kick the opioids off the receptors and naloxone will take its place. And that's how the opioid overdose is reversed.
Smart.
That's how the effects of the opioids, which is stopping your breathing, is reversed. So the negative to that is that if someone is very tolerant on opioids and they have a high dependence, it can bring on withdrawals immediately. You will sometimes have people waking up vomiting, peeing on themselves, whatever, because it will bring on that discomfort and that withdrawal. So please be aware of that it could be very uncomfortable for a person when you wake them up, but you're saving their life because otherwise they would die from not breathing, right? So naloxone is shorter acting than some opioids. Naloxone's half-life, which means how long it lasts, has a half-life of 30 to 90 minutes, so an average of an hour. Unfortunately, some opioids are so strong that they can stay in your system for a lot longer. Methadone, for example, has a half-life of 24 to 36 hours. So if someone is overdosing from methadone, those opioids will still be out there in their body, and when that naloxone wears off, those opioids will reattach and somebody could go back into overdose. So it's really important not to leave someone alone that has experienced an overdose, because in 30 minutes to 90 minutes, they could die. And that has actually happened. So if somebody experiences an overdose and you revive them with NARCAN, we need to make sure and either get EMS on the way, get them to the hospital, don't leave them alone. Excuse me. Come on, there we go. Okay, so I'm going to talk about a couple different types of naloxone today, and you guys here in the room are going to get to practice with them a little bit. The first one we're going to talk about is injectable naloxone. It is an intramuscular injection, and some people prefer to carry this, others don't. I'm not necessarily fond of needles, but I feel comfortable using it. I prefer to carry the nasal NARCAN. The benefit of this version is that it's a lot cheaper. We at times can get this donated, we can get it for much cheaper costs, and so making it available, sometimes that's your only option. It is very simple to use. I know you guys online can't see me demonstrating it right now, but I'll try and talk about it so that you can understand. Actually, I'm gonna stop sharing.
Yeah.
Because I'm going to be demonstrating several things right now. So I think it's more important for you to see me than the screen. Okay, so the first version that I'm going to share is the injectable. We used to hand this out a lot because we used to get a lot of it free. The COVID pandemic kind of cut back on the amount that pharmaceutical companies were willing to donate, so we're not allowed to get as much of it, but it is available in the community. I have small amounts available. So we used to hand out these kits, and they would come with 2 vials of naloxone. That's what the vial looks like.
I have a quick question.
Okay.
Does be administered similar to, say, like a diabetic shot?
So I'm not sure if that is I don't think that's intramuscular. The process would be the same, but I think you put it in a different place. Because like
The reason I'm asking is because I have 2 brothers. I have one who has G shots and one who has diabetic shots. They both like introduce it into their upper arm or their lower leg.
Yeah, then that would be intramuscular. Yep, that's exactly the same then. If it is intramuscular, then yes, it would be. Okay, so the kits come with 2 doses of naloxone and also a syringe and needle kit. So what you would do is pull out the syringe and the needle, and you would attach the syringe to the needle with a quick twist. You're gonna pop this little orange cap that's on the vial off. I already have one that's popped off here. So you uncap the needle. I learned a little trick from David Stoker again, that if you fill the vial with air, it will pretty much suck the medicine out on its own. So, make sure everybody can see this. So you insert the needle into the vial, you get it to where it's down in the medication. Sorry, I'm trying to let everybody see. And you blow air up into it, and then release, and it starts to pull out the medication on its own. You want to get every drop out of the vial, and then you're going to get rid of that extra air that's in the syringe. Then you are going to administer this in a large muscle, so that can be in your shoulder, in your thigh, or in your glute. You want to come in at a 90-degree angle, so straight ahead, because if you come in at like a 45, your needle could break off. So you're going to want to administer it at a 90-degree angle, and you're going to slowly depress the plunger, right? Then you are going to then you're going to safety cap your needle so that you don't get stuck, and that is how you administer the intramuscular version. All right, the next version I'm going to show you is the one that we're here to take home tonight, hopefully. It's called NARCAN. Again, that's the brand name. A box of NARCAN comes with 2 doses. These are really easy to open. They have a little foil cover on the back, so you just pull that foil off. I would not recommend carrying this alone in like a pocket or a purse, because that foil could come off and you could waste the medication. And I didn't mention it earlier, but 1 box of NARCAN can cost up to $150 in a pharmacy. So you don't want to waste the medication. So what you do is you pull off the foil. You're going to take the plunger and put it between your fingers, your 2 fingers, and then you're going to insert it into the nasal passage until your fingers hit the bottom of the nose. So you're going to put it until your fingers hit the bottom of the nose, and then you're going to depress it briskly. You're going to pop it almost, because that liquid that was in the vial is also in this, and so you want to push it hard enough that the liquid aerates and goes up into the nasal passages so that it can get into where it can be fully absorbed. This trainer I'll pass around to you guys and you can feel it. When you actually have a real one, it's going to be much more tense than this. It's actually going to be a pop. This one is very easy to push, and it wouldn't be like that. But that'll at least let you have a feel of what it would feel like. All right, the third kind of NARCAN or naloxone that I'm going to tell you about, you probably won't see this one often because it is so expensive. Excuse me. It is super convenient and it talks to you, kind of like an AED does. So it's really cool, but it's like $4,000 for a box of 2. And I think hospitals and law enforcement offices can get them for like $500 for a box of 2, but they donate a few and we sometimes get a few to hand out, but you don't count on it. Okay, so I'm going to show you how it works just because it's kind of cool, and maybe someday it'll be generic. You pull it off. That's very important to hear because one time on a Zoom.
You are ready to use pull off red safety guard.
Okay.
To inject, place black end against outer thigh, then press firmly
I'm gonna do my arm, not my thigh.
for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
Okay, so that's pretty cool, right? If you're not familiar with NARCAN and you might want to carry one of these around, I will tell you from personal experience that you want to make sure that you have the trainer in your hand when you're demonstrating it.
Oh, no.
Yeah, so my very first Zoom NARCAN training during the pandemic, all new to me, and I was like, oh my gosh, I gotta make sure the computer works, I do this right, and, I'm looking right. I accidentally picked up the real Evzio.
So you actually put it in.
And I actually injected myself with this. And at the moment that I realized that I injected myself, I thought so many things. But one of them was, I can't let them know I just did that. So I have to continue with my straight face and get through this without admitting to what just happened. And then when the Zoom was over, I yelled at my husband and was like, oh my God, I just injected myself with NARCAN. So let me tell you how that is really good experience for me though. Now I know to make sure, but part of what I teach in this class is that naloxone is very safe, that it will not hurt anyone. It has no side effects other than bringing on withdrawals, which is not a side effect, that's how it works. It has no danger to carrying it in your purse if a kid gets a hold of it or a pet gets a hold of it, because it's specifically designed, and not just this version, all the versions are specifically designed to only work on opioid receptors and opioids. So if I would have had opioids in my body, it would have worked. But I had no opioids in my body, so nothing happened, other than me having a slight panic attack. Heart rate went up a little bit, I was probably breathing pretty fast, but that was just me going, oh my God. But there were no effects because I had no opioids in my body. And that is why it is a very safe medication to carry. I feel very confident leaving my bag laying around, whatever, because I know if somebody accidentally gets a hold of it, it's not gonna hurt anybody. That's my 30-minute warning. Okay. I did learn, so typically when these drugs are tested, they're tested on adults, and so I'm supposed to say that these are for use in 18 and above, right? And that that I can't guarantee anything else. But I did learn during a NARCAN training one time from an OBGYN that they actually administer naloxone to babies when they're born. If their mother has for anesthesia gotten too much opioids in their system and the baby is having the effects of the opioids, they will actually administer naloxone to the child to revive it and to reverse those things. So that tells me, as a normal person, must be safe for kids, right? I mean, but I can't say that officially. So if you have a child that you think has gotten into something or is experiencing an overdose, I can't tell you, yes, administer naloxone, but now, knowing how it works, you can make that decision, an educated decision, whatever you would think. Same thing with a pregnant woman. Withdrawals are very, very dangerous for a pregnant woman, as is an overdose, right? So if you're pregnant and you're overdosing, you and the baby are going to die. They haven't tested using naloxone on pregnant women, but what's the alternative? They're gonna die, right? So I can't advocate for that, but I can say I know what I would do in that situation. I would probably save their life. Let's see. Should I go back? Okay, I think that's all the hands-on. Oh wait, yeah, we did that one. That's all the hands-on part, so I'm gonna share the screen again so you guys can see our slides as we go through. I'm just going to click through a bunch of them that we just covered. I will point out on this one, what is that bar up there? How do you make that go away?
How can you see?
You can move it to the side.
Is this a touch?
I got a question. Can we
No,
get
with
these slides
that,
as well, emailed to us or anything, so we can read over them? Or
Yeah.
no?
Yeah, if you drop me your email address in the chat, I'll be happy to email it to you. So that's, you're welcome. That slide right there, it just shows that you really want to depress it briskly so that it does aerate and get up in the nasal passages.
You should be able to just grab and drag.
Okay.
You got it? Yeah, there you go. Yay!
Okay, cool. All right, I'm gonna go back. Sorry, we're having some technical difficulties here in the room. Now I gotta get my mouse back to.
Be careful.
Side. Not that way. Oh, there it is. Okay. Wow. So let me go back. Ah, that's the one I want. Okay. So we've already talked about some of that. Oh, the last bullet point. So someone who's overdosed should not use any type of depressant following an overdose. And that's because when you add substances together, when you add alcohol with opioids, with benzos, they don't just add, they multiply the effect. They increase the effect substantially. So if you've had somebody that has just overdosed on an opioid, they're gonna feel really crappy, right? Because they're gonna be in withdrawals. They're gonna wanna go use something. Please, please encourage them not to use, especially a depressant like a benzo or alcohol, because that can help put them back into overdose. Wrong way. Okay, there's a lot of risk factors for an overdose. I'm only going to talk about one specifically, and that is period of abstinence, because it is the most important. So this was also something really cool that I learned. No matter how much somebody uses or how long that they've been using, so no matter how tolerant or dependent they are on opioids, after 3 to 5 days of non-use, their tolerance disappears. They are back to being opioid naive. So if somebody is in detox, if somebody is in jail, if somebody just said, hey, I'm gonna quit using, and they made it through 3 days of excruciating pain and withdrawals, they now have a tolerance of one of us who don't use opioids, right? So what happens is after that, they go and use the same amount that they were using before, they will overdose because their body is no longer able to tolerate that. So if someone is just coming out of detox or rehab or incarceration or anything, please make sure that they have NARCAN and let them know that it's very dangerous. If they are gonna use, they wanna use slowly. They want to use with someone else around. They don't wanna use behind a locked door. They wanna test their shot, and they can always add more, right? But they cannot take away. So just be aware that that is the #1 time that people will die of an overdose is after a period of abstinence. Okay, and sometimes it's really hard to tell if someone is overdosing or if they're just really high, because it's the same effects. It's just too far when they're overdosing. So there's a lot of things listed here. These are really good to know, but what I want you guys to remember, these are the 3 things you need to remember. This is how you tell that someone is overdosing on an opioid. Now, individually, these 3 things could mean something else. They might be related to a seizure or a diabetic episode or who knows what. But when you see all 3 of those things together, you can be pretty darn sure that is an opioid overdose. So what do those things mean? We have the depressed mental status or coma. So that basically means they're non-responsive, right? You're shaking them, you're yelling at them, you're doing a sternum rub, they're not responding to you. Ineffective or absent breathing. That could mean multiple things. It could mean not breathing. It could mean choking. It could mean gurgling, coughing. It could mean breathing slower than once every 7 seconds. If they're only breathing once every 30 seconds or once every 2 minutes, they're not getting enough oxygen into their body to keep their brain alive. And then the third one is very, very important because it's very different than other substances. Opioids make your pupils look like a pinpoint. They make them go very, very small. Where stimulants, on the other hand, make your pupils dilate and they make them huge. So if you see these 3 things together, you're pretty sure they're experiencing an opioid overdose. Now again, the great thing about naloxone is even if they aren't, you're not gonna hurt them. So if you even think remotely they might be experiencing an overdose, I would give them the NARCAN. In fact, we have a lot of paramedics that's just part of what they give somebody when they come up on scene and they're out, because it could save their life and it's not gonna hurt them. So those are 3 things. I have a sheet here in the room that has those pointers on it, and then for anybody else who's interested, I'll email these sheets out along with the PowerPoint, so you'll have the resources available that I'm handing out here in the room tonight. All right. Okay, So what should you do? You walk in, you find your friend unconscious, you check them, you shake them, you do a sternum rub, they're not responding, they've got those 3 things. First thing you really want to do, even though it shows 911 on here, is you probably want to give them 2 deep rescue breaths. Because if they're not breathing, you don't know how long their brain has been without oxygen. And that is what is going to kill them. So 2 deep rescue breaths, and a rescue breath is just tilting their head up, plugging their nose, 2 deep breaths, right? Then you either want to yell for someone to call 911 or call 911 and immediately administer the first dose of naloxone. Remember I said that naloxone takes 3 to 5 minutes to start to work? So during those 3 to 5 minutes is a perfect time for you to administer 30 rescue breaths. And that's how you'll know how long 3 to 5 minutes is. So you want to keep giving those rescue breaths. It's a deep breath every 7 seconds, and you want to give 30 of those. And then if they still haven't started to come around, you want to give them a second dose of NARCAN. So if they have an opioid in their body that's very strong, like a fentanyl, it may take 2 or 3 doses. There are reports of people where it's taking 4 and 7 doses. So there's kind of not a limit to the number of doses of NARCAN you can give them. You don't want to overgive it because that makes it hard on the hospital if they have to anesthetize them or something, but you don't want to not give it if you think that they need more. So typically our kits come with 2 doses. Sometimes people carry 2 kits, so they have 4 doses. Hopefully within the time that you've been given a rescue breath, EMS has arrived and they can take over, and they have the ability to do the naloxone through the vein, which is more it delivers to the system more. So just keep doing that rescue breathing. Even if you run out of naloxone, keep doing the rescue breathing, because if their brain is without oxygen, it's gonna start dying. So that's kind of the strange thing about an opioid overdose is their heart can still be beating. So you don't want to do compressions like you normally would in CPR if they're in an opioid overdose, because their heart's still beating and it's still circulating that blood, but that blood doesn't have oxygen in it because they're not breathing. So their brain is dying. 5 to 10 minutes after no oxygen to the brain, and your brain starts to really have some serious outcomes. So NARCAN and rescue breathing, super important. The rescue position is this all the way over to the right. If for some reason you have to leave someone alone, you want to leave them in the rescue position. And what that does is if they vomit, they won't choke on their vomit. The leg keeps them from rolling on their back or their stomach. And then the arm under the head keeps them from maybe having damage if they have a seizure or something like that. So if you have to leave somebody, that's the rescue position. You also can stand behind them so that if they are disoriented when they wake up and maybe they're striking out, you're out of range. Typically, naloxone intramuscularly and nasally is a slow wake up. So I would encourage you to Google some videos of people being saved with naloxone just so you can kind of get in your brain what that's going to be like. I've actually helped people who are experiencing seizures before, and it's very much like that to me. They wake up slowly, they're disoriented, they don't know what's happening. Most likely they either felt really good or really sleepy a few seconds ago, and the next thing they know, you're there doing things to them that they're like, what the heck are you doing? Or there's EMS or police, or there's gonna be some shock there. So just talk them through it. Say, this is what happened, we've got help on the way, you're gonna feel kind of crappy right now, let's just take it easy, talk them through it, encourage them, because they will be a little bit confused. All right, just talked about that, when not to use NARCAN, the only thing I'll mention on this slide is sometimes when someone passes out, there have been instances where they've fallen forward and hit their face and they're bleeding from their nose. So if they're bleeding actively, you're not going to be able to shoot that NARCAN up where it needs to be absorbed. So you can try cleaning it out. If you can get it cleaned out, go ahead and shoot it up there. Last resort, if you can't get it up into their nasal passages, you can shoot it under their tongue. It will also absorb there, but not as well as it would in the nasal passages, so you're still giving them a chance. But yeah, and cleft palates also can be an issue, so that would be an option when hopefully you have the injectable, or you can try it under the tongue. So there's a lot of myths out there. One of them that I like to address, there's 2 of them, and I skipped one of them. One of them is that fentanyl overdoses can happen by getting fentanyl on your skin, which is not true. So fentanyl powder does not naturally absorb through your skin. If you get fentanyl powder on you, you wash your hands with soap and water, you wash your clothes like you normally would, whatever it is. But just touching fentanyl powder will not cause you to overdose. Now, I would not suggest using like an alcohol sanitizer rub, because what's that designed to do? Absorb into your skin. So then that could potentially have some issues, but just touching fentanyl powder will not cause you to overdose. The other thing, another myth is that people who wake up are violent. And I'm not saying that doesn't happen, but in some studies, they only show about 4% of people that wake up. Most of them are going to be disoriented, they're going to be throwing up. They probably will be a little upset, like I said, because they just probably did something they probably shouldn't have done to get that hit of heroin, and now you've just ruined all that work. So I'm not going to lie, they're probably going to be upset, but combative doesn't happen as much as people like to say it happens. Almost done. Okay, some key things about storage. Don't store it in your car in the middle of summer, in the middle of winter, right? A couple hours in hot sun is not going to do much to it, but if you're consistently leaving it in a car in 100 degrees, that could be 150 degrees in the car over the course of a week, it's going to decrease the effectiveness of that medication. So I carry mine in my purse or my backpack so that I take it out of the car when I go with me. I've heard of people putting it in their glove box, and I'm not saying it's not going to work, but it's going to reduce the effectiveness of it. You want to avoid keeping it out of extreme heat, cold, and out of direct sunlight. So most of the doses that I have with me today have a 3-year expiration date. If you keep it, like it said, out of extreme heat and cold and out of sunlight, it has been tested to stay effective up to 99% for up to 96 months. What's that, 8 years? So if you keep it like you should, even though it's expired, it's still good. Now some policies at agencies, like for example, I work at a hospital. I could never keep an expired dose in our emergency kit at the hospital. That's not allowed. But a recovery center can keep an expired dose if they don't have state guidelines that prohibit them from doing that. So if you ever have an expired naloxone or NARCAN and you don't feel comfortable using it, exchange it. Find a place that is handing it out, give them your expired, and they will give you a new one, because we don't want it wasted when it can still save someone's life. Some of these are more to police officers, so I'm going to skip a lot of them. Okay, so what now? After Narcan, what do you say? So I'm not going to lie, my brother struggled with alcohol use disorder for many years when I was younger and not as educated about this as I am now. And I'm not going to say I didn't say a lot of these things to him, and probably very meanly too. I probably got very frustrated with him, and I made him feel a lot of shame and a lot of guilt and a lot of stigma. Because I didn't understand what alcohol use disorder was. And now that I've learned that these things don't help to encourage someone to seek recovery and enter treatment, I'm a little bit better about it. But I have done it, and it's easy to do because that's what our brains are programmed to do, right? That's what we hear in the media, that's what we are told, is that it's a moral failing and that people are bad because they use drugs. So I would recommend that you not use this terminology, and instead you try some of these things. Because they are more likely to make someone feel valued and cared for, and that they have hope, and lead them maybe to considering recovery. So it isn't a moral issue, it is a disease, and we have a lot of people who are successful in recovery and living great lives. So any more that we can be compassionate and non-judgmental and really encouraging people will help them in the long run. You can say things like, you know what, there's treatment available. Let me give you some ideas of options. Is there a sponsor that I can call? Do you have a family member that maybe would help you out during this time? You also, again, want to encourage them not to use, even though they will feel like it, because they could still overdose. And then I think person-first language is very important. A lot of the stigma that is created and around mental health and substance use is because we are identifying the person as that's all they are. So I told you about my aunt that's diabetic a little earlier. She's my aunt, she's a mother, she's a sister, she's a daughter, she is a teacher, she is a lot of things. She's not just a diabetic, that's just not all that she is, right? So when I call her a diabetic, that's what I'm saying that she is. Same thing with a person who uses drugs. If you are identifying that person as their only value and their worth is that they are an addict and they are a drug user, that is not who that whole person is. And I think there's a lot of power in language and how we can, maybe not among people who are currently in use, that language is pretty typical, but if I'm a professional and I'm calling somebody an addict, that is very shameful. I should not be calling someone an addict. I should be referring to them as a person who uses substances or a person who has a substance use disorder out of respect to them and their value as a person. They are more than their drug use. So these are just some suggestions on the left of words that are good to use and suggestions on the right. This is really important in media, and a lot of the stories that we write as a part of the initiative that I work for, we try to use this language so that we can express to members of the community who don't understand substance use that people are worth saving. Reporting, I'm not going to go super deep into reporting. If you get a free NARCAN kit from me, there is a website that if you were to use NARCAN on someone, they would ask that you go and report that overdose so that we can, again, collect that data that I talked about that was really important in the beginning. It's mohoproject.org/OD report. It's not going to collect like HIPAA protected stuff. It's not going to ask you their name and their date of birth and all that. It's going to be more like general information, like was it a public place where the overdose occurred? What was the zip code of the overdose? Was naloxone administered? Typical things like that, but it's not going to ask you like for personal information. But again, what that does is it sends a report to Missouri Institute of Mental Health, and they try and track those numbers so that we can get funding into our communities to show that we need more help to address this overdose issue. Oh my goodness, I think that's it. That's what sorry, go back. That is what the form kind of looks like. It's about 10 questions, but like this one is in what county did the overdose occur, and the zip code and the incident location. So it's very general information, and you don't have to choose an answer. So if there's one that you don't know the answer to, you just leave it blank, or you click unsure, or whatever. So it's a really easy form. Anybody can report to it. You don't have to have a login. It can be anybody that responds to an overdose. For those of you online that are interested in getting NARCAN, I'm going to stop sharing real quick. Okay. For those of you online that are interested in getting NARCAN, please drop your name and how many doses you would like, and if I can provide it, I will. If I can't, I'll connect you with Missouri Institute of Mental Health who can provide that. We do serve agencies, so if you are an agency like DOC and your office is interested in having NARCAN or NARCAN training, reach out to me that way. I will drop my email right now into the chat so you guys will have it and can reach out with any questions or needs. But we do have access to free nasal NARCAN. I've got kits here with me tonight, and I can get it to you guys who are online with us. Now, I think we have 10 minutes for questions. So, are there any questions here in the room? Let me start with that.
I got 2 questions.
Yeah.
Number one, in the very beginning, you're showing statistics. When do we know when they are going to be redone? Like we're going to redo the statistics.
So every year, more info comes out. So like this year, I'll get the next year's worth of info, and next year I'll get the next year's. It's always a couple years behind. So it's constantly being worked on, but they're always behind. So it's possible I could go back to my computer and look up some of these statistics, and they've already been updated. I just haven't gotten them updated.
Okay. Yeah. Okay. And then my other question is if we're going to borrow like an expired naloxone or the NARCAN, whatever they call it.
Yeah.
How long would you be able to keep that expired can before it would be completely effective?
It's been tested up to 8 years to be effective. So it's probably still good after 8 years, but we can only say it's good up until 8 years.
But what I'm saying is, like, after that 8 years, would you know how long would be a good idea?
I don't, because there haven't been tests done on it.
Okay.
So I can't say for sure.
All right.
I would guess that it's probably effective for a long time. I'm sorry, Brandy, what was that?
I have a question. What is the difference, or if there is, between methadone and buprenorphine?
Okay, so Methadone is what's called a full agonist. That means it is fully, fully activating those receptors, just like morphine would, just like heroin would. It is a full agonist. But it has over 50 years of evidence showing that it is a good treatment for opioid use disorder. The difference between it and buprenorphine is that buprenorphine is considered a partial agonist, and what that means is that it only activates the receptors partially, so it's much harder to overdose on because it has a ceiling effect, and you typically don't get the large sense of euphoria as you would with a full agonist, because it does have that ceiling on it. So that's the main difference between those two. But they are, in essence, both opioids. They just have different ways of working on the receptors.
But they don't feel like one works better than the other?
It depends on the person, really. So research has shown that both of them have been very effective in treatment. It really depends on the person and what their access is, how it works in their body. Right now, I will tell you that it's much easier to access buprenorphine than methadone, because methadone clinics are very restricted, and sometimes you have to go every day and get your methadone dose. So that's one of the benefits of buprenorphine, and it's also, again, much harder to overdose on the buprenorphine.
Okay, thank you.
You're welcome. Any other questions here in the room? Okay. I'm gonna.
Can you give us a website to tell where to find those statistics?
Yeah, some great ones. The state of Missouri, the Department of Health and Human Services has an opioid-specific website that I get a lot of those from. SAMHSA, SAMHSA.gov has a lot of statistics. The CDC has a ton of opioid statistics. The Department of Mental Health for Missouri has some statistics. Those are my go-tos. That's where I get most of my data from. All right, I'm gonna scan through. Sure, go for it.
Any way to document that we've had straight?
Yes. So I can provide it's a general certificate of participation. It's not like certified by anyone. But if you will drop in the chat your email and specifically say, please send me a certificate of participation, so I know that's what you're wanting, I will be happy to do that for you. I will say, if there are any law enforcement officers on here, that post hours are available for this training, and I do have the ability to give you post hours, so I would need that information in the chat as well to know that you need the post.
Thank you.
You're welcome. And before we close this, I need to save everything
Oh
for
yeah,
the chat.
I know.
Okay,
I was just gonna say, if anybody hasn't written their name on the chat, so when you have your full name, that'd be awesome, because I've got a few people, but I think somebody at the end joined in towards the end, so I need to know. Yeah, if you want to see, because a lot of people want certificates, so we understand that. But so if you want to put your emails on there,
Any questions?
what we're gonna do is we'll print this.
Perfect.
This is
That's
the best.
exactly what I need. All right, let me scroll through here and see if I see any questions. If you know you have a question and you want to unmute and answer it, that would be great. But let me scroll through and see if I can find any.
Just to clarify, for those of us who are on the video chat and who would like the NARCAN, would that be sent to us, or like how would that work?
Yeah, it just depends. If I'll contact you and we'll work out the best option. So it may be my mail, it may be me dropping it off by your agency, it may be us meeting up. We'll figure it out, but we will get it to you. Okay, I see a question that says, were users reporting using their own scripts or someone else's? So that was a very good question that I had. I think that's in referring to the study that was done by SAMHSA about the percentage of people that started out by misusing medications. They didn't clarify that when they did the study, and that was one question that I was like, well, I'd really like to know, was it their own or was it like someone else's that they were sharing? I assume it was probably a combination because they didn't specifically spell that out, but that's an excellent question. And someone wanted me to repeat the definition. I can do that. This definition is also available on NIDA's website. It's the definition that I use. There's a lot of definitions out there on what substance use disorder is or addiction is, but this is the one I like because it really hits some important stuff. Let me find it real quick.
So I noticed you were using a needle at first on one of those things. I think you said you'd shoot it up in the arm or something, like up the upper arm.
Yeah.
We don't have needle stuff. Is that okay? We don't have to do that. That's not.
Oh, no, that's fine. It is total preference. We have, right now, we have the nasal NARCAN to distribute, and so that is what I am gonna be distributing unless you're specifically looking for the intramuscular. I have a limited number of the intramuscular kits that I can provide you if you prefer that, but for right now, what I'm distributing is the nasal version, so that's perfectly fine. I found the definition. So the definition is addiction is a chronic, relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences.
I have to repeat.
Yeah. Addiction is a chronic, relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences.
Mm-hmm. Good definition.
All right, let's see. And again, feel free to unmute. I'm looking through for questions. Some good comments in here too. Sounds like a lot of you know some